So the cardiovascular system consists of your heart or myocardium, your blood vessels, which are going to be your arteries and veins. It helps with oxygenation and perfusion. It works with the respiratory and hematologic systems. Any problem in these systems causes the cardiovascular system to work harder to meet the oxygenation and tissue perfusion needs. Cardiovascular disease is the #1 cause of death in the U.S. Women get it more often than men, and there is one death every 40 seconds. So some A&P review. Blood flow through the heart. If you look at figure 33-2 on page 629, you can see that. So which valve separates the right atrium from the right ventricle? It's going to be your tricuspid valve. Which valve separates the left atrium from the left ventricle? That is going to be your mitral or bicuspid valve. And can you name 3 coronary arteries? The left main artery has 2 branches. It's got the LAD, which is the left anterior descending branch, and the LCX, or the left circumflex branch. And then there's the right coronary artery, or the RCA. You can see those in figure 33-3 on page 629. So this is a picture of the blood flow through the heart. So the right atrium gets deoxygenated blood from the body, via the superior vena cava and inferior vena cava. The right ventricle propels the blood into the pulmonary artery and lungs. The left atrium gets reoxygenated blood from the lungs to the left ventricle, and then the left ventricle gets the reoxygenated blood to the aorta and the systemic arterial circulation. So, what is the amount of blood pumped with each heartbeat? Each heartbeat pumps 60 mils of blood, or your heart can pump 5 liters a minute. Some common terms that are associated with systole and diastole. Systole is going to be the contraction or emptying, and diastole is going to be relaxation or filling. The correlation between the mitral and tricuspid valves and systole and diastole. During systole, the valves close to prevent backflow, and during diastole, the valves act as funnels to help move the blood from the atria to the ventricles. Still more review. So the MAP, everybody know what that stands for? It's going to be your mean arterial pressure. Needs to be greater than or equal to 60, and 60 to 70 is going to be required to maintain perfusion of major body organs. This is not important for test purposes this time per se, but it is important that you know that just in general when you're out there nursing. 60 to 70 is the number that you want to see for their MAP. So the primary pacemaker of the heart is going to be the SA node. Your normal heart, of course, I know that you all know, is going to be 60 to 100 per minute. So blood pressure, that's going to be the measurement of force that's applied to the artery walls. So for cardiac function, some concepts to know. You want to understand cardiac output, the heart rate, stroke volume, preload, afterload, and baroreceptors. So your cardiac output is going to be the amount of blood pumped from the left ventricle each minute. It does depend on the relationship between the heart rate and the stroke volume. This is important for y'all to know. So cardiac output is equal to your heart rate times your stroke volume. 4 to 7 liters per minute is normal cardiac output. So your heart rate, normal heart rate, is going to be 60 to 100. The parasympathetic system slows, and the sympathetic fight or flight increases the heart rate. Beta blockers, they are going to block sympathetic pattern by decreasing your heart rate. Stroke volume, that's going to be the amount of blood ejected by the left ventricle during each contraction. It does depend on the heart rate, preload, afterload, and contractility. Preload, so that's going to be the degree of myocardial fiber stretch at the end of diastole. Depends on venous return, fiber length, and the ability to stretch. It is the heart's maximum filling point. So Starling's law, that says that the more the heart is filled during diastole, the more forcefully it contracts. It does have some limits though. Afterload, that's going to be the resistance that the ventricles have to overcome to pump blood through. It is directly related to arterial blood pressure and diameter of the blood vessels. Impedance is going to be pressure that the heart must overcome to open the aortic valve. So if we think about it, a decrease in stroke volume can result from an increase in afterload. It leads to decreased cardiac output. So here's just a little slide over preload and afterload. So preload, the volume of blood in ventricles at the end of diastole or in diastolic pressure, is increased in hypervolemia and regurgitation of cardiac valves. And then your afterload is going to be resistance that the left ventricle must overcome to circulate the blood. It's increased in hypertension and vasoconstriction, and it does increase the afterload and increase the cardiac workload. So contractility, that's going to be the force with which the left ventricle ejection occurs. It does affect stroke volume and cardiac output. It is increased by sympathetic stimulation, calcium release, and positive inotropic drugs, and it is decreased by hypoxia and acidemia. So your blood pressure regulation, baroreceptors and chemoreceptors are present. Baroreceptors are found in the aortic arch and the internal carotid arteries. The chemoreceptors are also found there. So the baroreceptors are stimulated by the arterial wall stretching from increased blood pressure, and they do inhibit vasomotor center. Your chemoreceptors are going to be sensitive to hypoxemia. The stimulation results in vasoconstriction. So your baroreceptors are going to decrease your blood pressure, and your chemoreceptors are going to increase your blood pressure. So let's talk about some effects of aging. Calcification of valves can cause murmurs and rhythm changes. Conduction time increases, so PVCs may develop. Your left ventricle enlarges and stiffens, so oxygenation needs are not going to be met as well. Your aorta thickens, which can lead to hypertension, and your baroreceptors are less sensitive, which leads to orthostatic hypotension. For your assessment, you're going to want to make sure you discuss your patient history, discuss their nutrition, any family history they may have, so you can determine what sort of genetic risk they have. Current health status, their functional history. You can see that on table 33-2, which is on page 636 in your book. And then your assessments are going to be physical, psychosocial, and diagnostic. So your patient history, you're going to want to look at modifiable versus non-modifiable risk factors. Smoking, more than 20 cigarettes a day is 4 times the risk for cardiovascular disease. And then, of course, when you talk about their past history, you want to get their pack per years. You want to determine when they actually quit. A lot of people come into the hospital for an issue and they say, oh, I quit. And when you actually talk to them a little bit more, they quit when they were admitted to the hospital. So you want to make sure you have a good understanding of whether they're actually active smokers or, if they quit smoking 10 years ago. Exercise. You want to look at overweight versus obese. Your overweight population is going to be those with a BMI 25 to 30. Your obese population is going to have a BMI greater than 30. And then some psychological factors do increase the risk of heart disease. So if they're stressed out all the time, if they're angry, or if they have a history of depression, that may impact these things. And again, as far as your modifiable risk factors, those are going to be those habits that include smoking, drinking, drug use, diet, and exercise, versus your non-modifiable, which are going to be your age, gender, ethnicity, family history, and medical history. So for the medical history, you want to take a look at major illnesses that they have. These may include, or chronic conditions as well. These may include diabetes, renal disease, anemia, hypertension, stroke, bleeding disorders, connective tissue diseases, chronic pulmonary diseases, heart disease, and thrombophlebitis. You also want to make sure that you know if they've ever had previous treatment for cardiovascular disease. So why should we ask about tonsillitis, strep infections, and rheumatic fever? All of those may lead to valvular abnormalities, which we'll get into a little bit later. So that is why we need to know about that history. So drug use, you want to look at their use of over-the-counter medications, herbal and natural products, and street drugs. You also want to take a look at alcohol consumption, their nutrition when you're doing their nutritional assessment. You want to take a look at their sodium, sugar, fiber, fat, and cholesterol intake. So who do you think should be present for this portion of the interview? You want to make sure that you include family members that are responsible for shopping or cooking. Unfortunately, also, it's very common for people to say, oh, I don't eat that bad, and then, somebody else says, well, they eat 15 candy bars a day and every meal is from McDonald's. So it's just important to have somebody there kind of to help verify that nutritional history. And then you want to know if they have any kind of positive family history. So for a first degree relative, which is going to be a parent, sibling, or child, it's going to be a major risk factor for them. It's more important actually than hypertension, obesity, diabetes, or sudden cardiac death. So really important to get that family history. When you look at the current health status, you want to make sure you understand any symptoms that they may have. You need to know the onset, duration, sequence, frequency, location, quality, and intensity of the issues. You also want to know precipitating, aggravating, and relieving factors. So some major symptoms that are related to cardiovascular disease include chest pain or discomfort, dyspnea, fatigue, palpitations, weight gain, syncope, and extremity pain. Pain, if you look at table 33-1 on page 636, it addresses the assessment of chest pain. Then dyspnea on exertion and shortness of breath, you want to find out about their level of activity. So, can you walk 10 steps before you get a little short of breath, or can you take 2? And then their pillow use at night. Are they propping themselves up in bed? That's going to help gauge the severity a little bit. And then PND, which is paroxysmal nocturnal dyspnea. That is going to be caused by increased pulmonary congestion that's related to the inability of the heart to compensate for your increased venous return. These people will wake up in the middle of the night, shoot out of bed, and they feel like they're suffocating and they're completely panicked. So that is a telltale sign that you want to find out about. Fatigue, you also want to know when their fatigue occurs. Fatigue is often worse in the evening, and you do need to understand if it limits their activity. Palpitations, you need to understand if there are any precipitating factors. They may result from rhythm disturbances or non-cardiac factors, including anxiety, hyperthyroidism, caffeine, nicotine, and alcohol consumption. Weight gain, this is going to be looking at the fluid balance of the patient, and you want to know when edema occurs. So a weight increase of 2.2 pounds can result from 1 liter of fluid buildup in the interstitial spaces. So that's a lot of buildup. The best indicator of the patient's fluid balance is going to be weight. The patient may gain 10 to 15 pounds before edema is apparent. That's pretty major. And then you want to understand syncope and near syncope. Syncope is going to be when they have a brief loss of consciousness. It may be triggered by rhythm disturbances and valvular disorders, whereas near syncope is just going to be when they have some dizziness. So arterial versus venous insufficiency. Arterial insufficiency, they are going to have, they're going to be walking, have leg cramping, and it's going to be relieved with rest or lowering legs. And again, we will get more specific into these in a couple of chapters. Venous insufficiency is going to be related to prolonged sitting or standing, incompetent valves or obstruction, and it is relieved with elevation. So that's basically a key difference. Arterial is going to be relieved with rest or lowering the legs, versus venous is going to be relieved with elevation. Your functional assessment, you're going to want to take a look at the functional history. There is a functional classification of cardiovascular disability that you're going to find on table 33-2. That's on page 636. Your physical assessments, what is the importance of a thorough physical assessment? Obviously, physical assessment is going to be very, very important. So you want to take a look at their general appearance. Anything that you find in this initial physical assessment is going to serve as a baseline for comparison during and after treatment. So general appearance, you look at their build, skin color, distress, level of consciousness, shortness of breath, position, and verbal responses. So perfusion issues related to heart failure can result in confusion, memory loss, and slowed verbal responses. Also, chronic heart failure patients may appear malnourished and thin. Late signs of severe right-sided heart failure include ascites, jaundice, and anasarca, which is generalized edema, and that's going to be related to the prolonged congestion of the liver. So, skin, you want to look at color and temperature. You want to make sure you assess circulation in nail beds, mucous membranes, and conjunctival mucosa. Decreased perfusion is going to be seen as cool, pale, and moist skin. The patient may also have some pallor related to anemia. Again, they may also have some cyanosis. That's going to be a later sign, of course. And in darker skinned patients, the skin may appear gray rather than blue. Your extremities, you're going to be looking at vascular changes, looking for clubbing and edema. You want to make sure you check out their turgor and also ask about paresthesias. So with clubbing, I'm sure you guys know what that is. Their nail base is going to be really spongy. It straightens out to an 180-degree angle. Blood pressure, you want to look at if they have hypertension or hypotension. The textbook defines these as hypertension is going to be a pressure that is greater than or equal to 140/90. Hypotension is going to be considered a pressure that is less than or equal to 90/60. And then your venous and arterial pulses, you want to be monitoring for jugular vein distension, and make sure that you have those peripheral pulses. You can grade them, compare them. So your precordium, you're going to go ahead and inspect. You want to check out the point of maximal impulse. This is the pulse in the mitral area that's at the apex of the heart. It's also called the apical impulse. It is in the left fifth intercostal space in the midclavicular line. Figure 33-7 on page 639 goes through myocardial inspection and auscultation. So, your auscultation, what's the difference between the diaphragm and the bell? The diaphragm, you're going to hold tightly. You're going to hear high frequency sounds. The bell, you're going to hold lightly, and you'll be able to hear murmurs. Really important for you guys to remember, S1, beginning of systole, the AV valves close, and it is loudest at the apex. So, remember when you're going to be hearing your S1. Again, it's at the beginning of systole, when your AV valves close, and it is loudest at the apex. As far as your S2, that's going to be heard at the end of systole when your semilunar valves close, and it is loudest at the base. So now let's talk about extra sounds. S3 is known as the ventricular gallop. It's also called the Kentucky, just because of the cadence of the sound. So your ventricles are filling with blood rapidly, which causes vibration. Excuse me. This does indicate a decreased ventricular compliance. It may be an early sign of heart failure or ventricular septal defect in patients that are older than 35. Your S4 is going to be called your atrial gallop. It's also known as the Tennessee. It occurs as blood enters the ventricles during the active filling phase at the end of ventricular diastole. It may be heard in patients that have hypertension, anemia, ventricular hypertrophy, stenosis, MI, or PE. Your murmurs are going to be turbulent blood flow. They may be caused by stenosis or regurgitation, classified according to when they occur, and then they are also graded. You can look at table 33-3 on page 640 to find out more about that. Not important that you memorize, just gives you a general idea. Okay, so here are some videos. I would really love it if you would check them out. They're pretty cool, informational. I just like to see things sometimes, so I hope you watch them and enjoy them. Okay, so for your psychosocial assessment, you want to make sure you look into the patient's support system if they have any. You also want to be sure you understand their coping behaviors. So are they positive coping behaviors? Do they, talk to their friends about it or get it off their chest or whatever the case is? Or are they negative? Do they go out and get hammered? You want to understand what those are so you can kind of prepare the best for your patient. Denial is very important to remember. It is maladaptive related to treatment compliance. So obviously, if a patient is in denial, are they going to seek treatment when they need to? Probably not, because they don't feel like they have an issue. And anxiety. Anxiety is a very common thing related to anything cardiac. So you want to monitor for that. Your diagnostic assessment for your labs, this is really important for you guys to remember. So there's a chart on 33, there's chart 33-2 on page 641 that's going to give you the laboratory profile. Your cardiac markers, these are going to be what you need to know. So your troponins, your creatine kinase, your CK or your CKMB, and then your myoglobin. So troponin is going to be a myocardial muscle protein that is released with injury to cardiac muscle. So troponins T and I specifically are what they're going to be looking for, and they are not found in healthy patients. Troponins T and I indicate cardiac necrosis or acute MI. They have a wide diagnostic time frame. So your troponin T increases in 3 to 4 hours and remains elevated for 10 to 14 days. Your troponin I increases in 4 to 6 hours, peaks in 14 to 18 hours, and remains elevated for 5 to 7 days. So your creatine kinase, your CK, is going to be specific to brain, heart, and skeletal muscle injury. It indicates necrosis or injury. And the levels, again, follow a predictable rise and fall. Your CKMB is specific to the cardiac muscle, most specific for MI. It begins to rise in 3 to 6 hours, peaks in 24 hours, and falls over a 3-day total period. Your myoglobin is going to be your earliest marker detectable. It can be detected in 2 hours. It is found in cardiac and skeletal muscle. A myoglobin that doubles in 1 to 2 hours may signify an MI, though the value may still be within normal limits. So, if it's still within normal limits, but it does double, that may signify an MI. So, what I really want you to know about these cardiac markers, you do not have to know the actual levels of them. I do not expect you to know, their increase, peak, and fall times. You don't have to know that. I just expect you to know troponin T and I, CK, CKMB, and myoglobin, that those are going to be the cardiac markers that you're looking for. Continuing with your diagnostic assessment for your labs, you're going to look at the lipids. Total cholesterol should be less than 200. Your triglycerides should be less than 150. Your HDL, which is your healthy or good cholesterol, should be greater than 40. And your LDL, which is lethal or bad cholesterol, should be less than 130. Some other laboratory tests that may be assessed are going to be your PT-INR, that is monitored after initiating or maintaining therapy with PO anticoagulants. Your PTT is going to be monitored for those patients that are receiving heparin. ABGs are going to help you determine tissue oxygenation, CO2 removal, and acid-base status for your patient treatment. Your CBC, you're going to look specifically at the red blood cells. They will be increased with heart disease. Your H&H will be decreased with anemia, which can cause angina or aggravate heart failure. And your white count may be elevated post-MI and with various infections or inflammatory diseases of the heart. If you have an increased white blood cell count, it's a strong independent risk factor for CVA and heart disease. Your chemistry is going to be used to monitor your fluid and electrolyte balance, to monitor and also rule out causes of cardiac imbalances. So if you're having arrhythmias or things like that, they're going to look at your chemistry to make sure your electrolytes aren't out of whack. Some other diagnostic assessment, you're going to look at your X-ray. It's going to help identify the cardiac size, silhouette, and position. Angiography, is an invasive procedure. It's fluoroscopy with contrast media. It is performed when there is arterial obstruction, stenosis, or aneurysm that is suspected. So cardiac catheterization is going to be most definitive, but it's also the most invasive procedure. So pre-op, you're going to want to go over your indications. There is table 33-4 on page 643 that discusses those. Any risks associated with the procedure, you want to make sure to make those clear to your patient. You want to let them know what they can expect. Complications, there is a table 33-5 on page 643 that discusses some of those. The patient may experience palpitations, heat or hot flash, and a desire to cough while they're undergoing the procedure. Informed consent obviously is going to be very important, and as we learned in your pre and post-op, you are responsible as the nurse for clarifying, but the physician is responsible for obtaining the informed consent and educating fully on the procedure. NPO, the patient should be NPO after midnight. Obviously, sometimes when a patient needs a heart cath, it's going to be an emergency situation, and they're going to come into the hospital and go straight to cath labs. So they may have eaten 12 minutes ago. But as a general rule, you want to make sure that they're NPO after midnight. Fluids. Fluids are very important here. These are given 12 to 24 hours before the procedure to protect the renal function. This is going to help that kidney function because the dye that they use is so hard on the kidneys. I don't know if there is a standard protocol for this or not. I just know at the hospital here, we would do fluids at 100 for 6 hours pre-procedure and 6 hours post-procedure to help them flush that dye out of their system. And then your assessment, you're going to be certain that you monitor the peripheral pulses, chest x-ray, labs, EKG. You also want to make sure that you know if they have any allergies, such as to iodine-based contrast. So if they have a shellfish allergy, it's going to be important for you to know that. So for the procedure, do we do a right heart cath or do we do a left heart cath? The right heart cath is going to be done first if it is necessary, and it is used to diagnose pulmonary hypertension. Your left heart cath is used to identify the ejection fraction, and the flow through coronary arteries is going to be assessed, and then stents are placed as necessary. So in my experience, right heart caths are not very common. We pretty much always do the left heart cath. I have experienced right heart caths, I'm just saying. It's not going to be the day-to-day procedure that you see typically. For follow-up care, bed rest. Bed rest is very important, guys. Remember bed rest. So 1 to 6 hours. It may be more than that if the patient has an art line that is still in place. They will tell you when they bring the patient up from the cath lab what the bed rest restrictions are. You want to make sure that you look at several different things according to what type of procedure they had. So you're going to check out those assessment parameters. I really, really, really want you guys to know this. Know your bed rest, know your assessment parameters. So first, for a right heart cath, they may have a vagal response with sinus brady. So if they have a right heart cath, you want to be watching for a vagal response with sinus bradycardia. If they have a left heart cath, they are at increased risk for stroke. Now, with either the right or left heart cath, you always want to monitor for hematoma formation at the site of insertion. So whether they went through the groin or the radial artery, you want to very closely monitor those sites. And then you also want to monitor for dye clearance. So you want to make sure that the patient is having good output, no signs and symptoms of any kind of adverse effect from the dye. Vital signs. When the patient is returned to the floor from cath lab, they do post-op vital signs. So you're going to do every 15 minutes times 4, then every 30 minutes times 2, then hourly. At the same time as you're doing your vital signs, you're going to monitor again that site for hematoma and for any signs and symptoms of bleeding. You always want to assess the distal pulse. So very, very important to make sure, if they had a heart cath and they went in through the right groin, you always check the pedal pulses. Vital signs, again, very important post-op. And then signs and symptoms that you need to report immediately. Those are going to include chest pain, any rhythm changes, bleeding, hematoma, a change in distal pulse, slurred speech, dysphagia, and extremity weakness. So you just watch these guys a little bit closer. For a stress test, this is going to be used to assess the cardiovascular response to an increased workload. You can also identify dysrhythmias this way. Preparation, you want to make sure, again, that the patient is aware of any risks, that they have given consent. You want to assist them and prepare them for coping with the anxiety and fear, because these tests can be a little bit scary. They may have a light meal 2 hours before the procedure. Want to make sure that they do not smoke, drink alcohol, or drink any caffeine prior to the test, because this may affect the way their heart responds. And then beta blockers and calcium channel blockers are going to be held pre-procedure. Now, for the procedure itself, you want to make sure the patient understands what signs and symptoms they need to report during the procedure. So if they have any chest pain, dizziness, shortness of breath, or if they feel an irregular heartbeat, they want to make sure and report that. You're going to be monitoring EKG, vital signs, and then there's also the 2 different types of stress tests. So it can be an exercise stress test where they get on the treadmill or the stationary bike, or it can actually be a chemical stress test where they just lay there and they're injected with the medication. Echocardiography. This is the use of ultrasound waves to assess cardiac structure and mobility. Echocardiogram is going to look at the chamber size, ejection fraction, and the flow gradient across the valves. A transesophageal echocardiogram, or TEE, is an ultrasound that is done within the esophagus or stomach. And what it does is it provides more detailed views than the regular echo. Myocardial perfusion scan, that is also called an MPS. It is non-invasive. It's a nuclear imaging procedure. Cardiovascular abnormalities can be viewed using this. They may see MI, decreased myocardial blood flow, or left ventricular ejection. Alright guys, that's it on this chapter, so we're moving right along. And I think I've pointed out everything that you will need to know that's important. So I hope this was mostly a review, and we'll get right on to the next chapter.